Hey, thanks everyone, and thank you, Kim and the group for inviting me again to speak about that. But I'm Asbel Montez, and I am now a managing partner with a company called Solutions Group. That's a technology vendor as well. Most of you, when I think I spoke here last, I was the senior vice president for Acadian Ambulance Service, one of the largest privately owned ambulance services in the nation. But since the pandemic, I've kind of transitioned to a company that I've owned with my business partner for a few years now. I'm still doing great work with Acadian as well, but we're transitioned. So thank you for allowing me through this process. And this is kind of the buzz in the industry right now, is talking about the No Surprises Act, the impact to air and ground ambulance. For you that are joining online, or in the virtual platform, there is a Q&A button. If you do have some questions, I will try to get to them towards the end of the presentation. And then Kim, I'll kind of let you figure out how you want to dictate the Q&A with those in the room as well. But let's get to it. Probably talk about 45, 50 minutes on this, and then open it up to some Q&A. And there's a lot of stuff happening on this. There's actually some more breaking news that's happened that I got some information about an hour ago. We'll kind of walk through it. I'm going to keep it to what is happening in air ambulance, but also what we can expect on the ground ambulance side of some of the provisions that the No Surprises Act has addressed as well. Let's see if I can work through this. If anybody that wants to know a bit more about Solutions Group, you can go to our website. Also, though, I am going to tell you that I do a lot of webinars, and they're all on demand as well. A lot of the information I'm covering today, I've gone into some great length and detail. So feel free to go into those webinar archives. Stay tuned. I'm going to be coming out with another on-demand webinar on the independent dispute resolution process, or this part 2. Really have dissected it down and try to get it into the nomenclature that we speak in EMS, and try to simplify it when you're going through 500 pages of rules. So how is that relevant to the air, as well as what we can expect through ground? So this is a great site. Just kind of give you a plug there if you want some information, because I know I'm moving fast. But this is a great piece that you can actually download this stuff and look at it at your own leisure as well. Let me kind of go through the pieces that I'm going to be talking to today. I'm going to be talking you through an overview of that, and I'm going to break the impact to air ambulance into 4 sections. One is what we call the qualifying payment amount, or what I'm going to refer to as the QPA. The other is the IDR process, or that's the independent dispute resolution process. Don't we love all the acronyms, folks? We're an acronym industry, and we're an acronym government. And then I'm going to talk about the notice and consent provisions, and what that actually means to air ambulance, and does that actually factor into ground at all? The answer is no, but it is getting convoluted through the process. And then the cost data collection requirement for air. And then ground ambulance, I'll spend a little bit of time on that and what you can expect over the next 18 months to 24 months on the dialogue as it begins to play out nationally as well. Just as a disclaimer, folks, remember this is an informational only. I will be talking through some things that may have accounting or whatever. Always get with your experts or your CPAs on that as well. I'm going to give you guidance on this, but you should consult your own legal and accounting professionals as well. So let's give you a snapshot. Let's get right to it. So we do know that back on December the 21st of last year, at the very ending of the Trump administration, they did pass the Consolidated Appropriations Act. 2021 seems like a long year as well, but we are into the first year of the 4-year term of the Biden administration. So there's a lot of stuff happening right now. Some of the provisions that were passed at the end of the Trump administration are now being implemented and enacted under the Biden administration. So it's an interesting dynamic as this is playing out, specifically to the No Surprises Act, which was a provision within the Consolidated Appropriations Act that is now playing out in the form of interim final rules that are being published. Now, what's the difference between a notice of public rulemaking and what we call the NPRM process, or this interim final rule process. So under certain conditions, a lot of times if there is a provision that has to enact something at a certain time, a lot of times they'll try to use these powers to do kind of an interim final rule. So that really means that this is kind of a final rule. What you see is kind of what you get when it's published. They may make a few modifications to it, but generally speaking, most of the time you see an interim final rule, that is what they're going to be implementing. They do seek comments on it. Now, in a notice of public rulemaking, that is usually put out there. It goes through the normal rulemaking process. It's a 60-day comment period. They take the information back, and then they actually will publish a final rule down the road when it's an NPRM. A lot of times, notice of public rulemaking sometimes will stay out there forever. For example, many of you might remember here that the notice of public rulemaking, this was more related to ground ambulance, when there was a provision that was talking about contracting, and this is where we came up with that. People were contracting at Medicare rates minus a 16% or 16 2/3 percentage, and they referenced this notice of public rulemaking that was never finalized. So technically, because it wasn't finalized, it was never implemented or enacted, and they just typically go away. They kind of throw them out there for public rulemaking. I'm really simplifying that just so you understand why there's so much consternation from the healthcare industry related to these interim final rules with the surprise billing. So they've broken it up into two parts, and I'm going to walk you through those two parts now. So what does the No Surprises Act do? It amends 4 different areas. It's important to note, it amends your Public Health Services Act. So think the provisions that are governing under Medicare, Medicaid, that's where we fall under the Public Health Services Act. Then you're also looking at ERISA. So because a lot of the self-funded plans are the issue, they had to modify some of the code under ERISA. And then, of course, the Internal Revenue Code, and then the Federal Health Benefits Program as well, because of the federal health benefit plans. So there's 4 different areas. Now, this is an interesting dynamic because it has oversight with 3 secretaries: the Secretary of Labor, the Secretary of HHS, and the Secretary of Treasury. So it is requiring a trifecta, and hence the reason why you see a lot of people weighing in from different areas. See how much funding they gave to the implementation of the No Surprises Act. It's about $500 million just for the fiscal year of 2021, and it's to remain available until expended until 2024. So you can tell they're giving a lot of time and effort. This is a very, very important provision. And so typically, like I say, you follow the money to determine how important the provisions are. I mean, this is technically a bipartisan piece. I'm not sitting here to opine and preach to the choir about that this seems to be very payer friendly, and it is a very payer friendly rule. But unfortunately, it's where we're at. And so how do we modify it? What are we doing? And there's a lot of things beginning to happen from lawsuits being filed as well to challenge some of the provisions, and I'll walk you through some of that. So there are 4 key provisions, and I'm really simplifying, guys, this law just to bring it down to where we are and how it relates to us. But it does 4 different provisions. Of course, it takes the patient out of the middle. Everybody pretty much agrees with that, but it does take the patient out of what they call a surprise medical bill. Technically, if you purchase an insurance policy, you should know their limitations, so there really shouldn't be surprises. But however, we're not going to opine on that. But technically, it takes the patient out of the middle if they go to an out-of-network facility. This holds patients only liable for their in-network cost-sharing amounts. So think about the copays and deductibles that they would have paid had they used an in-network provider. That is what it holds them responsible for. And it does allow the provider and the insurance to move into some dispute resolution process that most are referring to it like a baseball style arbitration model. And I'll walk you through that. The legislation, though, does not set a benchmark reimbursement amount. The original fight on the Hill was they were trying to put in an actual benchmark. That was a negotiation that happened between the provider groups and actually Ways and Means with Energy and Commerce, and then Senate Health that actually stripped away that benchmark as well. And then it also requires providers and health plans to assist patients in accessing healthcare cost information. So think transparency. That's what it does here. So those are main 4 provisions. You can read the statute if you want to, or you can read through the rules, or you can listen to people like myself and others walking you through some of the parameters relative that are important for you to know. Now, how do we hold them accountable? Well, there's a system of reports. So there's a lot of things going around like, well, the insurance carriers are going to start monkeying around with providers, which they're starting to do, and take them out of network, try to drive the rate down so they can impact the qualifying payment amount. So there's several reports that Congress put in there that they wanted to be informed of any of issues that might be related to access or healthcare access, any changes of networks, anything that would result in higher out-of-pocket cost or premiums. Network adequacy was one of them that there's a GAO report on, as well as to talk through the independent dispute resolution process, if the boards of these IDRs have any type of relation or any conflicts or anything like that that would deter or that would actually defer to providers or payers over taking more of a objective view through the process. But do notice the time that these things have to happen. So it's looking like in 2023, you've got reports due in 2025 at the end of 2023. So even if there is some monkeying that goes on here, there could be a short-term impact to providers and payers, because by the time the reports are issued, by the time Congress is able to hold people accountable to it, there could be some damage to access and others. And that's why you're beginning to see a lot of news articles, a lot of scuttle begin to happen that you're beginning to see over the last several weeks regarding access and access provisions and how that's going to impact rural areas and super rural areas, specifically around, you're seeing some stuff, optics happen around the physician community, but also in the air ambulance industry. And then what is the impact relative to ground ambulance, because ground ambulance is now going to be all on their own, because technically they are not in the No Surprises Act outside of a provision to start an advisory committee to look at the issue. But I'm going to walk you through some concerns that we have with some of the interim final rules that were put out that's trying to put in some interfacility or a limited amount of interfacility in there as well, that we've been working very hard with the administration on to get clarification. So let's talk and let's bring this down to our industry. So of course, this includes all of the anesthesiologists, all the hospitalists and other type hospital-based physicians, the AMA, so think the American Medical Association, the Hospital Association, others are all included in this, but it's very impactful to the more of the physician community and very specifically to the air ambulance industry. So air ambulance, as of January the 1st, will no longer be able to send a bill to the patient for the difference between your bill charges and what the insurance carrier allows. You will have to take it up into a dispute process. The patient is out of the middle. And I'm going to stress that very closely, because a lot of people are thinking we're going to file an injunction against some of the provisions within the in it that the NSA is being interpreted incorrectly by the secretary. What you need to understand is it is clear in the law that effective January the 1st of this year, that is what, 6 weeks away, you will no longer, if you're an air ambulance provider, be allowed to balance bill a patient if you are out of network. And that's the piece between what you charge, your bill charge is, and what the insurance carrier allows. You can still bill them for copays and deductibles, okay? So that's very important to note. If you dispute with them, a lot of times you would just balance bill the patient, get them involved in the process and get them working with that. You're no longer going to be able to do that process anymore. So what does the air ambulance piece look at? So I'm succinctly breaking this down, and really, because we only have about 45 minutes today to an hour, I didn't go into a detail because I could opine on all these provisions, could take me 2 to 3 hours. And of course, you don't want to sit here and listen to me for 2 to 3 hours. But there's a lot of information where I have really broken this down in a webinar that I did about 2 months ago that's on my website. Go to that. I will succinctly take you through all of the methodologies and the formularies, but I'm going to broadly cover them today. So there are 4 things that you need to know if you're an air ambulance provider. The cost sharing amount that I am allowed to send to a patient that I transport is the amount that would be if I was participating. So how do I know that number? How do I challenge that number? That's the issue. And that is what's broken out in the interim final rule. And I'm going to walk you a little bit through that. So these cost sharing amounts will be counted towards the patient's in-network deductible as well. It'll also allow direct provider payments. So you that have been struggling where they're sending the monies to the patient as of January the 1st, that will no longer be allowed to happen. It will actually, you actually will get your payment direct to you, or your notice or your payment directly to you within 30 days from that claim receipt time as well. And it should be equal to the rate of what they call the recognized amount or the qualifying payment amount, and it should be made directly to the air ambulance provider. I'll walk you through what does it mean by recognized amount or qualifying payment amount. Most of the ambulance industry is going to be under the QPA, not under the recognized amount, and I'll walk you through the reasons why, or at least initially that will happen. Maybe in 2024, 2025, it might be different, but right now you're going to be working under the qualifying payment amount. So according to the law, or the No Surprises Act, the recognized amount is defined as this: the amount under specified state law as it is applied to the plans regulated by state law. Remember, in air ambulance, states cannot regulate the air ambulance rates or routes due to the Airline Deregulation Act. So this will not apply to you. Or it's the qualifying payment amount, and I'll explain that. Or if you're in a state that has an all-payer model agreement, then the amount the state approves. There's only one state right now that works on, and that's Maryland. So unless you're in Maryland, number 3 is not applicable to you. However, you're beginning to hear states start trying to do an all-payer model. For instance, in the state of Texas, they are now working to put together an all-payer model. So that's going to be interesting once they get all that information together. That's all happening. Take the state of Texas. You could move in 2024, 2025 into an all-payer model, and the QPA would no longer be the functioning thing. It would move into an all-payer model agreement. But that's how it's currently defined. So just kind of walking you through what that means. So I'm going to focus more on the qualifying payment amount, specifically because in the air ambulance industry, the ADA preempts the state side of things. And so the QPA is going to be what everybody is focusing on. And that is the main crux of the arguments happening right now, is how the QPA is defined, but more importantly, how the independent dispute resolution entity, where you are going to challenge if the insurance carrier doesn't pay you what you think what you think should have been the payment. This is where the qualifying payment amount becomes an issue, because the latest rule has indicated the presumptive value of the QPA. And so with the QPA now being presumptive, and I'll walk you through that here in a few slides from now, this is where you're getting a lot of the dialogue that's happening. And subsequently, the Air Ambulance Medical Association, or AAMS, has actually filed a complaint with the administration on the interpretation of the independent dispute resolution entity and the qualifying payment amount. So that just happened, I think, a few days ago. So you're seeing a lot of that begin to percolate as well. So what is the QPA? So let's just talk about 2022 right now. There is a formulary that they look at when you move into 2023, 2024, and subsequent years after that, how that is going to be calculated. But right now, it's very important on the 2022. What will it look like out of the gate, and how are payers going to be defining what a QPA is. So this is actually what the language says. So it's going to look at the amount in 2020 as your median contracted rate. So that would be of the in-network providers in your state. Now, there is a formulary that they're looking at specifically to air ambulance that would look at it by a metropolitan statistical area, what we call an MSA. So think in Colorado, it might look at Denver and all other areas. And so then it's going to look and see in that same insurance market, do I have at least 3 in-network providers for air ambulance that those 3 networks total more than 25% of the total volume? Or I have to move to a more regional approach that is going to look at the census areas. So you see, as I'm getting complicated into this, probably a lot of you guys are glazing over now, but you can see the formulary gets very complicated. And so how is this even a fair approach? So individuals that are on the high end, on the bottom end, technically a median rate is different than a mean. A median rate will kind of move out the outliers and move you somewhere in the middle. So technically, if you are on the high side, say for instance, you're in the 90th percentile of your bill charges or 100th percentile of your bill charges, you're going to lose in this process is going to be your concern about what your initial qualifying payment amount is. And so when the presumptive language comes in and says that the IDR entity has to look at the percent unless the provider can show credible evidence that they need to get a differentiation that is outside the QPA or the QPA is not looked at, this is where the concern comes in, as you can see. But this is how they're factoring it. Where you were or where the network was as of January the 31st of 2019. The reason why they put this number in there was to make sure that insurance carriers and providers did not start monkeying around in either getting out of network are trying to redo something. Now you're still seeing that happen because they think they can influence 2024, 2025. But right now, wherever the insurance market was with those contracted network rates as of January the 31st of 2019 is the benchmark look to establish the QPA for 2022. Okay, when they move into 2023, it's going to look at some other indices. The consumer pricing index of urban, it's going to look at some of the CPIU stuff there, or the HHS for new plans can develop the methodology, which they did, and then allow maybe another database. And that's kind of what we're looking at for the air ambulance industry, specifically because there's just not a lot of networks right now. You're seeing more and more move into networks, but that is typically after the date of January the 31st of 2019. So that's where it's going to be interesting what that QPA is in 2022. And the IDRE, or the Independent Dispute Resolution Entity, and how they are set up to manage this baseball style arbitration is extremely key right now. And that's why you're seeing a lot of buzz around that interim final rule that came out. So let's go into, because I've been talking about the independent dispute resolution. Again, guys, if you've got questions, please, I'll try to get to them after this piece here as well. And of course, I'm always open as we work through this process. But the independent dispute resolution process and how this entity is should factor in some of these components. Now, the rule came out that was 500 pages about 3 weeks ago. I will be doing a very in-depth webinar on this on demand to kind of walk you through those provisions, but many of the highlighted provisions and where the provider group went into an uproar was in there in the rule. HHS has instructed the IDR entity to make the QPA the presumption, okay? But you can see here the factors that was supposed to be established under the No Surprises Act. And these were the considerations that they were supposed to look at in equal parts, not one over the other. And so this is what they talked about was the QPA, which I've already kind of opined upon. They're supposed to look at training, experience, quality, and outcome measurements, the market shares of the parties, the acuity and complexities of the patients that you service, the training experience of your medical personnel, the type of ambulance vehicles, including their clinical capability. So not just the type, but also the clinical capability of them. And also the population density of the pickup location, not where your air ambulance base is, but where you pick up patients, as well as key, the good faith efforts of the parties to contract. Now, we all know that a lot of times the payers just gave you a rate sheet and said, here's your rates, take them or leave them if you want to be in our network. That is not a good faith, okay? What I'm advising people right now, because you're seeing a lot more carriers begin to reach out, or you've reached out to some carriers and they're stalling right now. You need to be documenting every single time somebody assesses something. Try to get it in writing, do it by email. I'm strongly suggesting you do not do by voicemail or talk, or if you do, you follow up with the gist of that in an email form and keep that information. This is going to help in the independent dispute resolution process regarding the good faith efforts, okay? I can't stress it more. Documentation, documentation, documentation is key. That's just a little lagniappe as we walk through this. So the factors that you're going to be looking at for the IDR entity that they cannot consider is your bill charges, or what they call your usual and customary rates and bill charges. I keep those synonymously with each other. And the payment rates by public providers. So think Medicare, Medicaid, they cannot factor those in at all. So they can't factor in the bill charges. They can't factor in Medicare rates and say, well, we're only paying 5% of Medicare. Or we want to pay closer to Medicare. Now, they may try to get that way in a roundabout way, but they cannot consider the Medicare rates or any federally funded rates. So think VA, TRICARE, any of that stuff, as well as bill charges. So let's talk about the interim final rule tool, rule part 2 that just came out, because this is where the issue is. Relative, and you need to understand that. And again, I'm going to key in, just because they give, if the courts actually give a temporary injunction to, let's say, to AIMS or to the industry regarding the presumptive QPA, and say they cannot implement that provision or that IDRE provision, doesn't mean that it wipes out the whole entire law or the balance bill side of it. Just remember, the patient is clearly out by statute. So as of 1/1, you cannot balance bill. Now, all these provisions could be log jammed for a little bit. So you may not have access to an IDRE process, depending upon what happens over the next 6 to 7 weeks, as we kind of work through what's going on with all of these complaints that are being filed, how the courts decide it, if it's appealed all the way up to the Supreme Court. This could take a while. And so what you may have is a process where you're having to sue. And you don't have an IDRE process to go through with all of these requisite timeframes that I'm going to walk you through. So it's important to note as we walk through here, and that's been some of the debate that the industry has been having, not just air ambulance, but health in general, is what's the pros and what are the cons as we work through this process. And that's one thing that's in people's key forefront is, where's my access through this? Could this become even more administratively burdensome, more laborious in process as we work through this? So in the interim final rule, now this is 500 pages and I'm condensing just down the QPA piece of this, but there's a cost data collection piece that I'm going to walk you through. There's a notice and consent in part of part 1 rule that I'll briefly overview that with you as well. But these are the key points that are talking through is the presumptive piece. So I've opined a little bit on that for you, but it establishes the QPA as presumptive. So basically it is the main category. All of the other factors can be considered by the IDRE entity as long as the provider shows credible information as to why. So some of the advice is to say, if we're not able to win that presumption, because that was not the intent of Congress, the intent of Congress was that all of the factors were equal play, not one over the other. The QPA was just one factor to the other 6 factors or 7 factors as well. But this, because the rule established the QPA as presumptive, and then the other factors could be considered if you have credible information, that is the issue that needs to be resolved through it looks like it's going to go through the courts. Provider or facility must show credible information. That's what I just talked about. And then the certified IDR entity should use the offer closest to the QPA. So basically in a baseball style arbitration, you're going to have, I think it's 10 days, and I've got the timeline here. You will give your best offer and the reason why. The payer will give their offer and the reason why. And then technically, the certified IDR entity should choose the offer that's closest to the QPA unless the information you provided was substantially substantive enough that they went with your offer. And if they go with your offer that's outside of the QPA, they are then required to report the reasons why to HHS. So I'm going to say that again. Then they're required, or the IDRE entity is required to report their information to HHS regarding why they did not choose the offer that was closest to the QPA. So as you can see, the IDR entity, they're only going to investigate those instances where the IDRE entity did not follow the presumptive QPA clause. So it's kind of a gotcha. As we know, it's almost like a passive aggressive way of saying choose always the presumptive QPA, or we're going to investigate the reasons why. Just want to throw that little piece out there. So if you've got questions about that, again, like I'm going to put you on, but I've got a few other provisions I want to cover that are important. But this is kind of where there's a lot more detail, and I kind of summed it up in 50,000 foot view for you. But just know the reason why we're paying close attention to this and why you should in ground ambulance is if you think they're going to reinvent the wheel for the ground ambulance industry, we probably have some swampland in Kansas that will sell you. So more than likely, this is going to be the template that they will follow. And when we do the ground ambulance side of things, so that's why we're paying very close attention to the methodology surrounding how they're coming up with the air ambulance QPA, as well as others and the factors considered, because we are going to need to make sure we address all of this in ground ambulance because of the impact that might be. So let's talk about the cost data collection piece. As you know, ground ambulance is going effective cost data collection on January the 1st. There is also an area here that the NSA provided that required a 2-year data collection reporting for the air ambulance industry. It has some similarities to ground ambulance, but it is nothing like ground ambulance, just so you know. Some people are trying to draw the correlation between the two, but the only correlation that I'm going to draw you to that are some of the components of the ground ambulance piece that they're extracting is relevant. It's similar, but there are a lot of nuances, guys, that could be very laborious. And I am strongly pushing and requesting for a delay of at least a year, because many ambulance services or air ambulance services, their systems are not set up to extract that data easily without it being a very manual process. And there was a few of us that were on a phone call with HHS leadership and Treasury leadership, and I really strongly pushed this piece and request, and it seems to be gaining traction to do a delay. But this is currently the way that it looks at. Health plan insurance issuers are going to have to do it on a calendar year, and so are air ambulance providers. It's not looking at your fiscal year. It is looking at your calendar year reporting. Now, they did seek comment on this as well, but their comment period was a 30-day comment period. And in the middle of the comment period, guess what other rule they dropped? IFR Part 2, and it sucked all the oxygen out of the room. And so the department did not get a whole lot of comments from the industry in general on these provisions regarding should they do calendar year or fiscal year. So just FYI, if you are on a fiscal year that's not related to your calendar year, they are going to be looking at calendar year reporting. This is what it looks like in a nutshell for you. Reporting year 2022, that if we're not able to get the delay, technically you're reporting 2022 year, you're going to have to report by the end or by March the 31st of 2023. And in 2023, you'll have to report by March the 30th of 2024. So what are those elements that they're going to be looking at? So this looks very similar to the ground ambulance side when they're looking at a few different things in the correlation. So, location of air ambulance bases and the number, that's kind of general. Your number and type of aircraft, transport mix. The interesting thing is the airport transport cost versus the medical cost. I think it's irrelevant. I think it's a dumb component to look at because you're already teasing some of the other stuff out. So that's an interesting thing that a lot of us have opined on to make you kind of go through the process and say, well, the flight, not the flight medic, but the pilot, that is air transport cost, but the medical costs are associated with the nurse and the doctor. And you have to separate all those costs out. Most of us do not do that. It's very laborious and it's fraught with error if we do that in assumptions that are not going to get to the reasons why they want to tease that out, because they are looking to see, is there a way to amend the ADA to allow for certain oversight and governance versus others. And I just think we're down a slippery slope there. But as you can see, these are some of the overview information. This is pretty much probably an easy thing that you can broadly get out of your either finance systems, but there's a lot of information that is being requested out of your billing or revenue cycle systems. Which is not the norm of what the ground ambulance is looking at. It's very nominal, the information that is going to need to be extracted from the revenue cycle side or the billing side. This is asking for a lot more information from ambulance providers, and they want it by the transport level. In ground ambulance, it's aggregate. In the air ambulance data collection process, they want it by every transport you do. So if you do 4 transports a day, in air, let's just hypothetically say it, every transport they're going to want this detail on. And that is where it gets really laborious because there's some components in here that are not in fields that are extracted by electronic data by an EDI function or what have you. And this is where I'm very, very, very concerned that the industry will not be able to provide the information, and it's going to be more harmful on the comprehensive report because it's not going to be to the point that we need the information. And so this is an area that I think we can actually do. It's just we got to set the systems up, and you got to work with vendors and revenue cycle vendors to come up with that information and how you're going to set up when you start your billing out of the gate. And we're 6 weeks from January the 1st or 7 weeks from January the 1st. And there's just not enough time to get all these processes set up. Hence the reason why I think there needs to be a delay. Okay. This is where it's looking at transport, like looking for your fuel, your capital medical, all of this stuff. While you guys may keep up with it, it's probably in a lot of disparate areas. And this is where I get concerned when they're wanting it down to the transport level data elements. They actually have these tools. The Office of Management Budget, or OMB, has already produced what these templates look like, where the data elements are that you could be sharing with your vendors or what have you, and how you're going to tease that stuff out. But this is the information that they're looking for, guys. Your number of transports, your denials by payer and reason. This is what we would call like a denials management report down to the transport level. So you that understand billing and reimbursement, you're beginning to probably, I'm painting a picture to understand, we probably have some of this information, but I have to pull out of here. I got to get the information out of here. And if I'm going to now have to manually key this stuff into whatever site, it can get very laborious. And we should have this in a thing where you can just extract the data in a file and then import somewhere else. So it takes the administrative burden off of the air ambulance provider as well. These are the payer categories. As you can see, guys, it's looking at different stuff. And this is similar to ground ambulance, but a lot of this stuff is getting down into a more granular level. And I will tell you this, the provider relief funding that we've all been receiving, and anecdotally, if you just want to know, they are sending out the phase 4 payments, you that applied for phase 4 funding. Smaller and rural providers are starting to see those funds as they started showing up on November the 10th. So you should see if you're a small provider right now, you should see this over the next 7 to 10 days. If you're a larger provider, expect it sometime the 1st or 2nd week of December. I'm just going to throw that out there to you as well. But the provider relief funding data collection piece, or that reporting piece, a lot of people were calling and had not actually had not bifurcated some of these primary pay categories. For instance, Medicare and Medicare Advantage, they didn't have bifurcated. And they were asking for that information. Okay. And so some of you guys were having to make some assumptions through the process. This is my concern. We're not set up. We're not ready for it. We were under assumptions. People said they were ready for it. And as we got down into the granular detail, I think maybe they were making some assumptions that they thought they were ready and they weren't. Here's additional transport level detail. Contractual arrangements with each plan or issuer with the air ambulance industry is probably nominal right now because many of you are not contracted. You that are, they're going to want to know by each plan and issuer based upon each transport you do. Your payment methodology, your claims payment. Some of this stuff you can already extract and get out. A lot of this information is there, but what if you appeal a claim and the outcome of that appeal? A lot of times people just put that in a note section, and it's not something that is an element that you can extract out pretty quickly. You have to redefine your practices to start allowing for that so you can pull it out as well. These are different things that are elements that are needed in order to provide or produce this comprehensive report that I'm going to discuss right here. So this is what they are required to provide as a public report. So this is public. This just isn't for something that they're going to refer to Congress and give to Congress. This is going to be available to all stakeholders. And we all know that the patient that you're transporting typically isn't the one that's really going to be the one reading the report to figure this out. We know this is going to be stuff that legislators are going to look at. Legislators on the state level are going to look at. Your local politicians, your mayors, the insurance carriers, those that are whatever, those are the stakeholders that are going to be looking at this comprehensive report. And that's where the concern of a lot of us is to make sure that the data that we extract is as accurate as possible. Why you can't control it, you can't control the data elements. And that's why I feel we need to slow down. I think HHS has captured a lot of the data elements appropriately. The problem is they do not correlate to how we currently do business as in general as an industry. So here's what they've got to provide. They've got to provide the percentage of air ambulance providers that are for-profit, not-for-profit, municipal, hospital-based. The competitive advantage or analysis of the air ambulance providers, average charges, growth studies. They want to look at the growth of the air ambulance industry in rural and urban areas over time. They also want to look at the percentage of that are contracted versus not contracted, your debt collection practices, your patient billing practices, your frequent claims that you're appealing, things like that, the unreasonable market concentration or excessive market domination that enables unreasonable price increases. This is the information in a comprehensive, it's required by statute, and they're going to be using these data elements in order to produce that information, not just what we produce, but also coupled with other data that's coming from the FAA, that's coming from Treasury, that's coming from other components they can use, and then merge it all in with these data elements as well. So this is the reason why I'm spending a little time on it, for the industry to educate themselves on what we're talking about here. There's a lot of information that I have done on this. I've done another comprehensive webinar specifically on this. I provided you with the tools of what they're looking at, giving you the direction to. I suggest you go there. It's free. You can just scroll through it in your leisure time. If you want to listen to me walk through that again, I would strongly suggest you listen to that as well, and I'll kind of walk you through the process. But we are seeking a delay. I think it's wise that HHS, several of us have been talking to CMS and to the individuals that are actually writing this stuff and giving our opinions on this, and how they should go about doing it and why they should do it. And so it seems to be resonating. They did bring it up again on why we think the delay should be. And thankfully, I was able to kind of point out the elements that would be hard for air ambulance providers to extract without setting their systems up correctly. And so that kind of resonated with them on the administrative burden. So if we can get a delay of at least a year, and this comprehensive report could be done in 2025 versus using 2022, 2023 data, we'll use 2023, 2024 data. And I'm almost done, guys. Notice and consent. So this is an area where there's been a lot of questions on, does air ambulance have to do these notice and consent provisions? How does this actually work or not? Okay, so let me just give you the two provisions in the notice and consent so you're not confused. Specifically to air ambulance, patients of air, this is very specific in the in the notice and consent provision statutorily, as well as what was opined on in the interim for final rule part 1. Patients of air ambulance services cannot be asked to waive balance billing protections through a notice and consent process, okay? In some of the physician community and others, there are some provider groups that can. Notifying, and there's a whole notification process that, you know, it looks at 3 days out, it's the same day services or whatever. But just know, patients of air ambulance services, you cannot ask them to waive their balance billing protections through a notice and consent process. The regulations, though, do not require the air ambulance service, though, to publicly disclose information on the new law and its requirements to patients receiving their services, okay? So some of the provider groups, there is a requirement that they actually publish this stuff. That this regulation does not require air ambulance service, though it is strongly encouraged that you do it. And you provide that as a customer service friendly approach, but it's not like if you don't do it, there's a penalty associated with it. The next thing is good faith estimates. This has come up, and this is a good faith estimate requirement if you have a self-pay patient. So think you have a self-pay patient, or you've got somebody that's insurance and they want to get a good faith estimate from you over the phone. A lot of you guys are already doing this. It's not for rotary wing where it's usually happening after the fact, but a lot of times in fixed wing, or somebody's calling around asking for a good faith estimate, you typically already do something similar. There is certain information, though, that they've got in required fields that you'll need to do. So you might have to modify that a little bit. But for the most part, this is not going to be very impactful to the industry unless somebody calls you after the fact, or they want to get a good faith estimate of what your service is, and they call you and they're a self-pay patient or what have you. A lot of you are already doing this, and there's some different requirements that you might ask or whatever. So you might want to look at the forms. The Office of Management and Budget has some examples of what the forms should look like that you can use as templates. But typically this kind of walks you through. Most of you are already doing this. You may just need to change a little bit to your process. So a lot of times we talk about the timeline. So if I'm going to dispute this, say for instance, and we'll be Pollyanna here, say for instance, the presumptive QPA and all of this, of these complaints that are being filed by many of the communities, the AIMS has filed a complaint as well on the presumptive QPA with the independent dispute resolution process. But let's say there is not an injunction or a temporary injunction given on the IDRE entity process. And so you have the ability out of the gate in January, if you get a payment that you dispute or a denial that you dispute, and you want to go through the IDRE process, what does the timeline look like? Here is what the timeline looks like for you. So you're thinking it's going to be relevant to about 127 days, I believe. You guys are probably seeing it in my thing, but my block is covering this. But it looks like 30 days, they have a requirement to either pay or deny. Okay, then you move into an open negotiation period of 30 days. And this is 30 business days. They're opining on 30 business days, not 30 calendar days. So, you know, think about 30 business days is probably going to look a lot like 35 to 40 calendar days. If you're looking at, depending upon the month. If you cannot get in the open negotiation period to agree on an amount with the payer, then once the 30-day lapses, you have 4 days to notify the HHS secretary and the other party that you want to initiate the independent dispute resolution process. Okay, you've got 3 days for the provider to jointly certify the IDR entity that you want to arbitrate the bill. And then it can be in the 30 days in the IDR entity process for them to come back. Now, in between that 30 days, there's certain time frame. Like you got to have it in 10 days, you got to have that piece in. Then it tells them what they've got to do and back and forth to go through. But within 30 days, they need to have it resolved. Once they resolve it, you can expect about 30 days before you receive your payment, and it'll be direct to you. So as you can see, you're looking at about 127 days from the date that you submit the claim to hopefully some additional payment showing up in your account. And that's in a perfect world. We all know that we don't live in a perfect world, but that's the timeline, and that will be what they will associate with it as well. Enough about air ambulance. So ground ambulance, what do we have to expect, and why are we paying so close attention to what's going on in the air ambulance space? We were very successful installing the ground ambulance piece, and this was a concerted effort of the International Association of Firefighters, the American Ambulance Association, who I'm extremely involved in, the National Association of EMTs, and whatever other alphabet soup we had. But there was a lot of concerted group effort to stall this. And that was because a lot of people were making assumptions about the ground ambulance industry that we are distinct and unique, and we know that, but a lot of people don't understand that. And so it needs to really go through an advisory committee. So we were successful installing, and unfortunately, Ed and Labor at the last minute put in a provision that they wanted to have an advisory committee stood up. And so that resonated with Energy and Commerce, Ways and Means, and Senate Finance and Health picked that up. And so at the end of the year, this is what we ended up with: a ground ambulance advisory committee that technically was supposed to be enacted 60 days following the legislation. As we know, that has not happened, but we did get some breaking news about 2 hours ago that we are expecting the formation or the call for nominations to happen either later this evening. We should see a notice, or no later than tomorrow evening, and we should see that notice happen. And then there's going to be a really quick 21-day turnaround for the nominations, and then hopefully we will have it published in the Federal Register before the end of the year, the first kickoff meeting relative to the advisory committee. But this is what the advisory committee is supposed to focus on: the qualifying payment amount criteria and the independent dispute resolution key criteria. That is what I'm strongly suggesting as we work through. Don't reinvent the wheel. We're going to educate providers. But if you think that we are not going to be folded into getting the patient out of the middle, I think we're kidding ourselves. And so what we have to do is we've got to work through this piece and figure out what are the two areas that could be detrimental to the infrastructure of the ground ambulance piece. Whether that comes back with a core thing that says that the QPA is defined by whatever the local regulatory governing agency has defined it to be by their local taxpayer, whether we open up and the recommendations that are going through is that Congress also needs to address that we're the only healthcare industry that doesn't get paid unless we transport a patient, versus every patient that we respond to, there should be a fee relative to that as well. So those are different things that we need to be thinking through. And I think it resonates in the payer community because we are the one healthcare entity that, especially in the emergency space, that only gets paid when we actually treat a patient and transport them somewhere. So those are areas that I think that we can nuance, we can make sure people are educated on, and that's also going to the reason for the increased cost, as well as the increased reimbursement rates that they're seeing in the ground ambulance industry. Also, the independent dispute resolution criteria needs to change and modify. There was precedent set by the air ambulance industry to add 3 components that were really reflective of just their industry alone, and we have the same nuance in ground ambulance. And as you can see, I'm saying don't reinvent the wheel. We need to be practical about this. This is the conversation that's happening, and we can pretty much expect that we're going to be gunned for. We're already being gunned for that ground ambulance is the only outlier in this whole balanced billing, surprise billing argument that has not been addressed by Congress. And so just know now we're out by ourselves. We work with the collective whole. So hence the reason why there's a lot of us making sure we've got to get the Ground Ambulance Advisory Committee started before the end of the year, because in the court of public opinion, they are going to think they are never going to get a balanced bill when they call 911. And so while you are technically out, and a lot of people are technically out, and they're saying, oh, we're out of this. In the court of public opinion, I can guarantee you your phone's going to start ringing next year at the very beginning saying you can't bill me. And you need to have a plan in place on how you are going to address those issues and how you are going to work through those pieces as well. Here, guys, is where I'm strongly suggesting you bookmark this email or this website, https://. It's on the screen that you can see. I strongly suggest you will get a copy of these slides. I believe Kim will get these out to you. This is a hyperlink. You can click on that, but this is where they are going to be putting, and there's going to be a resource, all things No Surprises Act as well. And all this stuff that I'm talking about, all these policies and procedures are listed here. A lot of the information, you that are data wonks and love to look at stuff like this, this is where I would strongly suggest. There's also a listserv that they're allowing you to get alerts that come through as well. And of course, I'm more than happy to continue to keep working through that, but I'm strongly suggesting that you do this here. Here is my email address. I'm going to open it up to some questions as well, or turn it over to you, Kim, if you want to facilitate the Q&A side of things. If there's any questions for you guys as well, but strongly suggesting, here's my email address as well. And then here, follow me on social media. Too, and I'll try to get the information out. I also have an email listserv too. If you want to join that, I'll push out information as it becomes relevant to the industry too, to make sure that you are kept informed, because informed ambulance services make better decisions as well. So thank you for giving me the chance and opportunity to talk to you. And I wish I could have been there on site. This is the second best way to do it. But thank you for that. Kim?
Thank you, Asbel. Some scary information you're providing there. I do have an initial question for you. You mentioned the patient payments, that when an insurance sends it to the patient, and that's going away for the air ambulance.
Yes.
Is that going to go away for ground ambulance also?
Not under the current No Surprises Act. So if you've got insurance carriers still directing payments to the patient, that is not a provision that is going to impact, the direct pay provision is not going to impact ground yet. Now that will be discussed, and you can pretty much assume that once ground ambulance comes under the No Surprises Act, whether it's 12 months from now, 18 months from now, then all payments will be going direct to provider. That is the contingent of, if we can't balance bill a patient, then direct pay has to go to the provider. So, but right now, ground ambulance is not included in that.
Okay, so hopefully in time we'll see that. Any questions here in the room? Mr. Dienst.
Hey, Asbel.
Hey, bud.
I thought I saw a memo come out recently that said that non-emergent transports were going to be impacted by this No Surprises Act a lot sooner than even this, before this committee was created. Is there any truth to that? So that non-emergency transports are going to be impacted first? That's a significant, scary.
Yeah. So I will tell you, so the No Surprises Act was very, very clear on the intent of Congress that ground ambulance was not included. Okay, so if we wanted to challenge it, and we have actually drafted a letter to the secretary. We've had numerous conversations with CMS, because in the interim final rule that they published, which was part 1, where they talked about the qualifying payment amount, the notice and consent provisions that I talked about, they came out a few months ago. In there, they liberally interpreted and made it very vague that there were some components of IFT, or the interfacility transfers, that could be included in there. So think most of these would be discharges after post-stabilization for higher level of care, that they would be included in this. Now, as a ground ambulance supplier, if you are non-hospital based, it's clear that that is not in there. Okay, if you're hospital based, the argument is pretty sound that more than likely you are going to be included in this current provision as a hospital based provider. That is still being mulled over by CMS at this point in time. I will tell you, our last phone call with them week before last is they thought that all IFT was done by hospital-based providers, or hospital air ambulance, or hospital ground ambulance providers, when technically less than 7% of the ground ambulance services are hospital-based. So 93% of all transfers that happen are done by non-hospital based ambulance providers in the IFT space. I know that's kind of going around a little bit because there's a lot of information out there with people, but ground ambulance could be impacted only statutorily. We are covered. I'm not worried about the provisions. There will be several of us, if they do not do that, that will challenge it, that they cannot do that, and we'll win in the court system. I mean, it's just clearly there. It seems CMS agrees with us on that. We're just waiting for the clarification for them to, we just want them to clarify that ground ambulance is not included in the No Surprises Act. That'll take care of all the plaintiffs' attorneys that will start calling thinking non-emergency ambulance services included. But I want to stress the point of the court of public opinion. The court of public opinion is a lot different than the legal opinion. And so just have a plan in place of how you're going to address that piece as well. But that's the piece that I think we have, but it's not really anything statutorily that's covered under the NSA. It's more the court of public opinion is going to think they are. So.
Okay, and once again, when you mentioned earlier in your presentation that usually what comes out in an interim rule becomes the rule. So if these provisions are already going to be applied to the hospital-based services, how do we even know what those are? And will those ultimately get extended into our world? So do we have to fight and look at those rules now to make certain that they're, I guess, good for us or applicable to us? Or because I'm afraid that those are going to become our rules because they were already established.
Yeah, so that's the work that lots of us have been doing, because like I said earlier, why we're paying very close attention to what's going on in air ambulance, because more than likely that's going to look very similar to what ground ambulance, not exact, because of course there's a lot of different nuances. But if we think that Congress is going to reinvent the wheel for ground ambulance, which makes up 0.83% of the overall healthcare spend, I mean, no, we know that's not going to happen. So understanding the issue was something that Congress agreed with. They understood how complex our industry was. And that's why they wanted to get an understanding before they actually amended us into the NSA. And so we understand that's why there's two factors we've got to focus on, is really making sure that Congress understands the qualifying payment amount as it would relate to the ground ambulance industry. And then the factors that the IDR has to consider because of how locally controlled we are, which is different than any other healthcare provider in air ambulance. And so that's really going to be a crux of a lot of the information as we begin to educate and work through this Ground Ambulance Advisory Committee.
Thanks, Asbel.
You bet.
Other questions? Chris?
Yeah, I was just wondering if like that hospital-based model that you're talking about for IFT, would a way around that be for them to then start billing Part A rather than Part B and capture it that way? Because
I'm thinking you mean to do the exact opposite. So if you're a hospital-based provider doing Part A, maybe you want to switch and become a Part B provider to get out of the rule. That's what I would suggest you do. Part A providers, it's going to be interesting. There's a lot of us that just don't see how they're going to be able to amend themselves out.
Got it. Okay.
Thank you.
Are there
Bet.
any negative consequences to switching? I mean, if you're already a Part A hospital-based, I mean, and switching to a Part B, are there those
I would really
that may benefit them as an A versus a B?
Yeah, I would go back and look at it. The hospital-based providers that I'm talking to, a lot of them are already in network. They are already in network, or they're part of the system, or their whole healthcare system has already negotiated in network rates and things like that. I just don't see it probably as big of an issue for them. There are some that operate in silos. So I'm not discounting that piece of it as well. So I don't think it's going to be as impactful to them as it would be to the ground ambulance Part B, just because of the current practices of insurance carriers in establishing a QPA. There is no good faith. And they just cut rates and they're paying you at either some percentage of Medicare. Now in Colorado, the law that you guys passed with what are you guys at, 250 or 325? It's something like a percentage of Medicare. Is that
Yeah.
right?
Yes.
That is going to be an interesting piece because that would be the governing premise. So you guys in ground ambulance, because it only covers right now, it doesn't cover the ERISA funded plans, or the state of Colorado doesn't. You guys would actually be probably a winner if you are comfortable with that rate as a percentage of Medicare, where you get direct pay on everything. So that's going to be just an interesting dynamic because there's 7 states right now that have addressed ground ambulance rates in some shape or form. And the current definition of the qualifying payment amount looks at if the state has done something, that becomes your premise. If they've stayed silent on it, then this QPA formulary comes in. So, you know, when I was talking about the recognized amount, so you guys in the state of Colorado, you guys might say, I would love to be included right now in the NSA if they can direct payments on everything to me. So all payments come to me now. I'm fine with going there as long as they have to pay me. My QPA is around that recognized amount of 325 of Medicare. But other states are going to hate it. And so you see the issue as we're going to be working through the Ground Ambulance Advisory Committee.
Other questions? Questions online? I don't see anybody. I'm the dummy in the room here, and you probably already stated this. Who is the IDR, and how do you know? I mean, it seems like you can pick the IDR. Who is this?
Okay, so the IDR entity is going to be an approved or a certified entity that HHS is going to certify, or Health and Human Services are going to certify. And so it is now open for nominations or applications. And so it could be a law firm down the street in Denver. It could be 50 people that are entities that you have the ability to choose from. And so they're going through that process right now. They will be posted on HHS's website. And so you and the provider, if you go into the dispute, is going to select and jointly agree. If you can't agree on who you want your IDRE entity to be, then the secretary will assign one from that list. And there's an approval process they have to go through. You have to make sure that none of the board members or none of the executives actually work for the air ambulance community or for the payers. So that's going to be just really, really interesting as we work through that process.
Wow. All right. Asbel?
Another question.
Okay, another question, Tim?
Is urbanicity going to play in this process? I know it does under CMS and Medicare, urban, rural, super rural. Do you see that going to play into this equation?
So
So how are we going to correct the inequalities in that determination?
So what a great question that's loaded, and hence the reason why the factors that the independent dispute resolution entity must consider as equal factors, because that is one of them. The population density, the geographic area, the urban, rural, frontier states, that is extremely, extremely important. Is why one of the factors are there. Now, CMS is opining the reason why they want the presumptive qualifying payment amount there is because they're saying that the rates that have been developed already factor that in. And we know that's not accurate. We know they're not doing that. Now, in a perfect world, if they were doing rates like that, and that's how negotiations happened and rates were set according to that, then that naive assumption that CMS has made relative to that would be accurate. But that's the reason why the healthcare community is pushing back, because we know the rates as they are established. A lot of times, if you're looking at in-network rates, the negotiation typically usually has nothing to do with that, especially in air ambulance or ground ambulance. It's, oh, I could beat my competitor out, so I'm going to give you this rate so I can get more volume from you.
And I get that, but I mean, there are problems now with the urbanicity determinations. I mean, I'm one of those services that's more rural than I am urban. but I'm caught up in that urban MSA and I get urban rates, even though
Yeah.
I.
So, yeah, so in the ground ambulance, this is where cost data collection will be able to tease this out, but we are 2025, 2026 before that happens. So more than likely, we are going to be enveloped into the No Surprises Act before then. So what we may have to do, like an interim shift, like a 3-year sunset provision that actually establishes, which a lot of us are kicking around now, is maybe doing something similar to what you did in Colorado, to the Vermont did, and do it as a percentage of Medicare that then sunsets once the data collection becomes available. And then you can really look at it a bit more, because technically the Medicare fee schedule, and I'm using this loosely, guys, factored in all the geographic productivity, the GYPSI, that's what the GYPSI is about. It's supposed to have factored in all of those super rules with all of those modifiers. We know it's not an exact, but it might be like an interim way to get there until we get the data collection out. But until then, we need the ability to go through the independent dispute resolution if we agree with the QPA amount, so we can dispute the amount that looks at that population and geographic disparity in equal parts. But if they keep the presumption in there where it's always the QPA unless you have credible evidence, then you're going to have a credible evidence model that says, in my territory and area, I only have 1,000 people per every whatever. Then you would have to build that to try to argue that point before the independent dispute resolution entity. Welcome to the new world of healthcare for the next 24 months.
Any questions? I see nothing in the room and I see no questions online. Asbel, thank you so much for your
I do
presentation.
have a comment.
Oh, we have a comment?
It's a lot more fun when you're here.
I'll have to do it the next time in Colorado because I love your great state. Thank you for those kind words.